Hello dear viewers, continuing with our series on antibiotic selection for difficult to treat organism or resistant organism. In this video I am going to discuss about Carbapenem-resistant Acinetobacter baumannii infection. I am Dr. Sunil Garg. Welcome to Essentials of Acute Care. In the last part of this video, there are few questions based on this video for viewers to solve and discuss. There are multiple challenges with regards to treatment of crab infection. Not only it is related to empiric therapy, but it expands to include patient where culture is positive for this organism. Most of the empiric antibiotic regime used in the critical care setting does not cover this organism, so this pathogen remains uncovered and treatment gets delayed because of this reason. Hence, decision to treat for this organism in empiric regime requires consideration of multiple patient variables. Once the organism is identified as crab, this situation is not straightforward and this also poses management challenges. As this organism is mostly recovered from respiratory secretion and wound, it becomes difficult to differentiate between colonization and the true pathogen. Once this organism is resistant to carbapenem, it becomes resistant to most other antibiotics which are usually expected to be sensitive against this organism. So treatment options becomes very limited. There are no standard of care antibiotic regime against which effectiveness of other antibiotics can be compared. The general treatment approach is combination therapy for the management of crab infection. The preferred antibiotic therapy is ampicillin-sulbactam given as infusion in high dosage. It is important to note here that this therapy of ampicillin-sulbactam should be given even if organism is resistant to this compound during sensitivity testing. This compound should be given in combination with one more agent out of polymyxin B, cefiderocol, minocycline or tigecycline. It is important to understand that the crab infection should be managed with combination of antibiotics even if the organism is sensitive to all antibiotics. There are various reasons to this approach. High bacterial burdens are expected with this infection as there is almost universal delay in initiating effective antibiotic therapy against this organism since common empiric antibiotic regimes are generally not active against crab infection. Also, there is possibility of rapidly developing resistance to ongoing antibiotic, so combination therapy improves the likelihood that at least one active agent is being administered. Ampicillin-sulbactam is available in 2:1 formulation and the total dose per day of sulbactam component is 6 to 9 gram of the sulbactam as extended or continuous infusion over 4 hours in 3 divided dosage. Tetracycline derivative minocycline or tigecycline is given in combination with ampicillin-sulbactam and minocycline is preferred over tigecycline. Cefiderocol is the only novel FDA-approved beta-lactam agent with in vitro activity against this organism. Cefiderocol is given as a part of combination therapy, but cefiderocol is used only when first-line agents cannot be given. Here are few questions. You can read them as per your convenience. Please pause the video to read each questions and you can discuss with me their answers in comment section box. Thanks for watching this video. Please subscribe to this channel and I assure you up-to-date information through my channel. I appreciate your feedback and suggestions and bye for now.